Hello to everyone here present today. My name is Joana Palhotas and I'm a student from the University of Escola Superior de Tecnologia e Saúde from Lisbon in Portugal. In this current moment, I'm a finalist and I'm doing my internship in Nutrir, a nutrition clinic from Cordoba in Spain. And today I'm going to present semaglutide, monotherapy and combined therapy and with diet and exercise for weight loss in type 2 diabetes. To begin my presentation, I would like to talk about numbers. Current estimates suggest that approximately 10% of the world's adult population has type 2 diabetes, and in Spain, this disease affects 5.3 million of people. In recent years, there has been a significant increase in the therapeutic options available for its treatment. Obesity can be described as a chronic, relapsing, and progressive disease. And the most common clinical complications include cardiovascular diseases, metabolic diseases like type 2 diabetes, other dysfunctions such as sleep apnea, and malignancy. The Organization of Economic Cooperation and Development show that 13 to 90.5% of adults worldwide have obesity, and the prevalence of obesity is projected to continue to rise. And with the pandemic of COVID-19, it got even worse. So to conclude, the underlying factor for type 2 diabetes in most cases is being overweight or obese. So, semaglutide is a GLP-1 analog with 94% sequence homology to human GLP-1. Acts as a GLP-1 agonist receptor that selectively binds and activates the GLP-1 receptor. GLP-1 is a physiological hormone that performs various functions in the regulation of appetite and glucose, as well in the cardiovascular system. This drug reduces blood glucose in a glucose-dependent manner by stimulating insulin secretion and decreasing glucagon secretion when blood glucose is high. This mechanism also involves a slight delay in gastric emptying in the early postprandial phase. Semaglutide also reduces body weight and body fat mass by reducing calorie intake, which normally implies a general reduction in appetite. In 2018, was approved by the FDA as a supplement of diet and exercise for patients with poorly control of type 2 diabetes. But nowadays is also used for weight loss for people with or without diabetes. And for this reason, it would be a tool for the nutritionists in the future for the treatment of obesity combined with therapy and diet and exercise. For this review, 24 scientific articles published to date were analyzed, whose focus was the effects on weight loss, satiety, daily intake, and adverse effects of semaglutide and its two commercial forms, subcutaneous and oral. Only 7 of these studies investigate semaglutide combined with diet and exercise versus a control group, placebo or lifestyle modification alone. And now I'm going to talk about the most important ones and its results. The first 2 studies that are worth to mention are SUSTAIN-1, a phase 3 trial double-blinded, where was evaluated the efficacy and safety of once-weekly subcutaneous semaglutide monotherapy versus placebo in patients with type 2 diabetes and also overweight for over 30 weeks. The findings revealed that body weight significantly decreased with subcutaneous semaglutide monotherapy in 95% of the analyzed subjects compared to placebo. The other trial is PIONEER-1, a randomized clinical trial that evaluated also the efficacy and safety of oral semaglutide monotherapy compared to placebo in patients with type 2 diabetes. The findings revealed that oral semaglutide monotherapy achieved body weight reductions of minus 26.9% and minus 41.3% with the doses of 7 and 14 milligrams respectively. And now I'm going to talk about the STEP trials because they were able to provide a rigorous evaluation considering the use of semaglutide 2.4 milligrams once weekly to treat people with obesity with or without diabetes. Step 1 and Step 2 trials revealed a body weight reduction of minus 14.9% and minus 9.6% respectively, with semaglutide combined with exercise and diet versus the control group. The difference was that the patients in Step 2 were also with type 2 diabetes. And the placebo group in Step 2, besides the lifestyle intervention, there were a placebo, visual matching placebo drug. Semaglutide combined with intensive behavioral therapy in Step 3 showed a weight loss of minus 16% versus minus 5.7% observed in the control group. This control group had the same diet and exercise exposure. Regarding weight loss maintenance in Step 4, the body weight change of minus 7.9% in the group with semaglutide plus diet and exercise observed from week 20 was maintained until week 68 compared to the patients that switched to placebo group that gained plus 6.9% of their weight. Step 5 will access a long-term trial of 2 years, 104 weeks, with semaglutide in participants with overweight or obesity, and it will be published in this year. This will be an important study to see long-term effects and to provide vaster knowledge when using this GLP-1 analog. Several trials seem to demonstrate that semaglutide represents a new and effective drug that can be used to improve the health and quality of life in obese patients in weight loss with type 2 diabetes. Nevertheless, further studies and more evidence is required about the interaction of semaglutide with lifestyle modifications such as diet and exercise, even using different therapeutic protocols. In other matter, the cost of semaglutide for weight loss and type 2 diabetes is still very high for the common population compared to other GLP-1 RAs and metformin, and this can also be a problem in the adherence of patients. Also, it could be crucial to know if the protocol used by the different studies includes the less modifications in this current data, because there are several side effects that can provoke a major or minor impact, and we must evaluate every situation in each subject. Gastrointestinal events such as nausea, vomiting, abdominal pain, heat burn, belching, and diarrhea are the most common adverse reactions. In Sustain 1, Pioneer 1, and STEP trials, these events, like nausea and diarrhea, led to premature discontinuation of treatment reported by 11 to 24% of the patients. Less common adverse effects include acute pancreatitis, cholestasis, and complications with diabetic retinopathy. There appears to be more gastrointestinal discomfort with semaglutide compared to other GLP-1 RAs, and this may affect adherence in clinical practice, especially in patients with previous gastrointestinal diseases, and for this reason could be crucial to put the advantages and disadvantages on the scale when using this drug with the primary goal of weight loss. Concerning the durability of these findings, because as long-term risks and benefits are still unknown, it must be a conscious and informed decision before being used and prescribed. A broader knowledge would provide a better guidance and recommendations for health professionals. To conclude my presentation, semaglutide monotherapy has shown significant weight loss in patients with type 2 diabetes. The combined therapy of semaglutide with diet and exercise has been shown to be effective in achieving significant weight loss versus placebo or control groups, and further studies of this subject will be necessary. Thank you very much for all of you, and this ends my presentation.